Hello everyone, I'm Alexander Bondarenko and I'm gladly introduce you into the pathology. Today our first lecture, it calls, okay, surprise introduction to pathology, and also it would be after that I will start with the second lecture, first part of that, cell injury with explanation of the general mechanism of cell injury. Well, as you may see, I turned the presentation from the first slide, and this is the shield of our root of pathology. The idea is that any great thing, any interesting event in our life for sure associated with the travel. So in our department, we decided to make this appearance of the lectures as the route, as the way when you on different stops will study the appropriate topics. Today we got the starting point, and I want to introduce you a little bit to pathology. Before I will begin, I would like to ask you, please register yourself for the lecture attendance. Well, you have to just write your name and the group and dozen into the live chat. Well, let's start. First of all, what the word pathology actually means? Because if you don't know the meaning of the subject what you study, so what the sense to study that, right? Well, as you may know, any word with the logy or something in the end is associated with the Greek origin. So from Greek, this word consists of two parts. First one, there's the pathos, in suffering, and logia, study of. So study of suffering, right? But more precisely, definition of word pathology is, okay, let's figure it out. What is that? The first MCQ on this lecture. That's the criminal horror movie or the study of disease, music band, or predicted or actual progression of particular diseases. What do you think? Yes, for sure, B and D, that's the correct answers. However, A and C also somehow associated with pathology because there is both criminal horror movie with the same name and music band. However, B and D is more reliable for our current situation. Then, in theory, the pathology study, this is actually what you will do during this academic year, as the branch of medicine, branch of biology in general, concerned with the study of the nature of disease, as the biology of the disease, and its causes, processes, development, and consequences. Practically, however, the pathology is the medical specialty that provides microscopy and other laboratory services, for example, cytology, histology, to clinicians. Historically, the history of pathology is coinciding with the same milestones as in the development of the medicine. That's antiquity with the Greek and Roman and Indian and Chinese contributions, or contribution of an antique civilization, is rudimentary understanding of pathological processes. Middle Ages with the decadence of science, except medieval Islam. Then Renaissance and Enlightenment with resurgence of the natural sciences and new universities, and the discovery of microscopy method. And then modern era, then the term pathological anatomy, anatomical pathology, pathomorphology appeared. And by personalities, I just want to emphasize on several of them. There's Giovanni Battista Morgagni, his contribution to development of autopsy method. Austrian doctor Baron Karl von Rokitansky with his contribution to establishing a microscopy method as a basic one for the pathological study, and for sure the father of modern pathology, German Dr. Rudolf Virchow. You will be faced with different eponyms, means the words with terms containing the names of the author. For example, Virchow's triad, and we will discuss about the pathology of hemostasis or Virchow's cells, etc. And Lauren Ackerman as the founder of the modern surgical pathology, as the prominent personalities who were influenced on the development of the modern pathology. Nowadays, it consists of two branches, and we are dealing with anatomical pathology or pathomorphology. That's the same. It's about the gross microscopic, chemical, immunologic, and molecular examination of organs, tissues, and whole bodies. It includes it's subdivided into different sub-branches like cytopathology, histopathology, surgical pathology, etc. Clinical pathology, this is about the laboratory analysis of bodily fluids and tissue extracts using the tools of chemistry, microbiology, hematology, and molecular pathology. You are studying now the pathophysiology. That's about that. Then it's time to discuss about the purposes, right? So, why you need to study pathology? What is its role in the medicine at all? How to understand that better? And for that, I prepared the well-known, I guess, short funny story about interaction between different specialists in the clinic, and it's reflected in the interaction of them in the leisure activity. And you can imagine that four doctors went duck hunting one day. The group of the hunters included the internist, radiologist, a surgeon, and a pathologist. After a time, a bird came winging overhead, and the first to react was the internist. And he raised his shotgun, but then hesitated. He started to thinking. He started to think. I'm not quite sure. It's a duck, he said. I think that I will have to get a second opinion. And of course, by that time, the bird was long gone. Now the bird appeared in the sky soon thereafter, and this time, the radiologist threw a bet on it. She too, however, was unsure if it was really dark in its sides and besides. So, and then she thought I will have to do some more investigations. So, and the creature made good its escape. Finally, a third bird appeared. At this time, the surgeon's weapon pointed skywards, and he fired without hesitation. And then, boom! The surgeon lowered his smoking gun and turned nonchalantly to the pathologist beside him. Go see if that was a duck. Will you? And he responded, I'll get back to you in a week. So, that's the partial truth for sure. There are a lot of much more complicated things. Anyway, superficially, this is like the impression, how we interact with each other. Honestly speaking, pathological study purposes consisting in these points. For diagnostics, that's the determining the cause of disease. We call it etiology. Also, in this case, practically we're trying to figure out how disease develops. That's about pathogenesis. We performing the pathological study compare the morphological and clinical manifestation, that's so-called clinical morphological or clinical pathological comparison. And also we perform the diagnostics and trying to predict the complications and outcomes. Also, the big large piece of our job, that's the post-mortem inquiry. autopsy activity, where we determine the factors contributed to death, uh, carry out a profound insight into the pathological processes, and somehow prevent the death in future. That's a big hope for sure. And also estimate the care quality. To reach these objectives, we need to use the reliable and adequate methods. For that reason, we apply the appropriate reasons and the appropriate level of biological organization. For example, for the autopsy, that's about it. For autopsy, we apply it for the investigation of the entire organism on the systemic level, trying to find some signs of the disease and interactions with different components of our body. Then after the surgical extraction, very frequently we achieve the organs or fragments of organs, uh, and then perform the gross examination. That's the gross inactivity. Then after that we harvest the parts of the organs, tissues. Even after autopsy we perform the necropsy, and these tissue samples then could be treated with specific microscopic techniques, and thus we achieve the slides, then perform histology, cytology, and even more sophisticated methods. With the contribution of immunology and genetic, we can detect genes in the tissues. We can find some specific proteins which could be responsible for the pathogenesis and etiology of the current process, etc. And in the pre and subcellular level, very rarely we can use other methods, but mostly they are associated with the research activity. That's more for the science. Autopsy as a method couldn't be underestimated. We still perform autopsies, and that's the only way to understand the nature of death, the nature of the diseases. As you may know, the famous proverb that morgue, that's the place where dead teach live people. So the autopsy or post-mortem inquiry, that's the thorough examination of the corpse by dissection to determine the cause and manner of death and to evaluate any disease or injury that may be present. There are different types of autopsies: forensic, clinical, anatomical. For us, we are, as a pathologist, we perform the clinical autopsies. As about the anatomical autopsy, that's for teaching, for study purposes. Forensic autopsies, that's the branch of the legal medicine. And you see that different artists in the past were impressed by the work of the pathologist. It's very impressive job. Very impressive job, and see that's exactly the painting of Enrique Simonet, who painted this autopsy room in 19th century. This is how it looked like at the time. Then this is another very famous painting by Rembrandt, and it illustrates how the autopsy looked like in the 17th century. In fact, that's the autopsy for teaching purposes, for studying purposes. That's not real post-mortem inquiry. Anyway, that's from 17th century. And nowadays everything has changed. You'll see COVID-19 turned things to another reality. So that's 21st century autopsy, right? Yeah, for sure not. The modern autopsy room looks like that. Biopsy. That's another tool that we use for collecting the specimens of our tissues for diagnostic purposes, but sometimes biopsy coincides with the surgical procedures. For example, surgical removal of some lesions, tumors that we call excisional biopsy, got two purposes. First, the surgical removal of the lesion by itself, and then second, this lesion is delivered to our department, and finally, we investigate the tissues, investigate the tumors, and trying to identify the pathological process. However, there are some other types of the biopsy. For example, incisional biopsy, that's only diagnostic purpose biopsy. Then there is the surgical removal of a fragment of lesion or fragment of organ. In core biopsy, then we perform the core biopsy of inner organs by thick needle, and there is the sample, very thin sample of tissues, which is enough to identify pathological process like the liver core biopsy, kidney core biopsy, etc. What next? After the harvesting of the tissue sample, we need to do something to create, to make, to carry out the histological slide. How to do that? For that reason, there is the conventional tissue processing. We call it paraffin, formalin fixed, paraffin embedded specimens. This method requires first fixation in the 4% formaldehyde, then dehydration in the increasing concentrations of alcohols, then treatment with clearing agent, basically that's organic solvents. These steps we perform for a reason to remove the water from tissue. That's about the dehydration, obviously. And fixation is proposed to stop all biochemical processes inside a cell, to avoid the decay, to avoid the bacterial contamination, and to avoid the lysosomal digestion, self-digestion of the cells. So anyway, dehydration is proposed to remove water, but why we need to remove water? Because the end step of this tissue processing, as you remember, I told you that's paraffin embedded into the paraffin. Why we embed the specimen into the paraffin? Because paraffin could be easily molten and could be easily solidified. So after the solidifying of paraffin block and tissue specimen embedded to the paraffin block, we can cut it with the special equipment. We call it microtome, with a very sharp blade into a very, very thin slices, approximately 3 or 5 micrometers in thickness. And after that, we put the slices on the glass and observe it on the microscope, under the microscope. Not yet, because histological slides of our tissues, they're transparent. Our tissues are transparent. Some pigments are present like hemoglobin, hemosiderin, melanin, but that's not enough to visualize all the cellular compartments, tissue compartments. So that's why the very important step in the histological processing is the choice of staining technique. Staining technique choice it depends on our study purposes. Basically, routinely prepared hematoxylin and eosine is pretty enough to visualize all major compartments of the cell and observe these cells and tissues under the light microscopy. So as you may see, the blue staining, that's the hematoxylin. Structures which are stained with the hematoxylin we call basophilic. See the nuclei as the basophilic compartments of the tissues of the cells. Sometimes we see the basophilic structures in the cytoplasm. That's structures which comprise the nucleic acid as well as DNA in the nuclei. That's RNA in the endoplasmatic reticulum. Eosine, in its turn, is staining the proteins, extracellular and intracellular proteins, and the structures which are stained in eosine, they are pink in the middle image, you see. That's eosinophilic substances, eosinophilic structures. You see, basophilic, blue, eosinophilic, red. And then we merge these two blue and pink pictures. You see the combination of hematoxylin and eosine. And now you see all structures are visible. Stroma, parenchyma, intracellular, extracellular components, nuclei, cytoplasm, everything is visualized. But this staining is not really specific. If we want to identify the specific components like carbohydrates, we apply the specific staining that we call PAS, that's periodic acid sheaf staining. In this case, we identify not only carbohydrates, but also carbohydrate-contained structures like carbohydrate proteins. Like here, the basement membrane, it contains a lot of carbohydrates, and that's why the basement membrane of glomerular apparatus, GBM, also could be stained with PAS. It's very useful in case if we have the problems with the GBM and after the certain diseases like glomerulonephritis, it's pretty easy to use PAS to check out what's going on with the GBM. Also, we use our knowledge in immunology to detect the specific proteins in the tissues, because we know that some specific immune response could be produced against the specific protein. And with that knowledge, we may produce artificially the required amount of specific antibodies in the laboratory animals or other culturing medias like cell cultures. We can produce enough of these antibodies to use it in the diagnostic for the diagnostic purposes. For example, we need to detect the specific protein in the tumor. So we know this protein, and we know we have some they know the structure of this protein. They have some amount of native protein like that, and we can produce some immune reaction against that. So we produce enough amount for the immunohistochemical reaction. Then we apply these antibodies incubated with the tissue sections. And the tricky thing that antibodies could be tagged with different substances, like fluorescent tags. Then in that case, we can observe the histological structures under the fluorescent microscope and see some fluorescent structures. That means the presence of the SIGIN protein. Also, we can use immunohistochemical method. In that case, the same approach. We produce some specific antibodies against the SIGIN antigen, against the SIGIN protein that we are looking for. But in this case, the antibody is tagged with the substrate enzyme complex after the incubation with the chromogen, which could be changed into the insoluble stain. So we can visualize the presence of the tissue antigen that we are looking for. It's better to demonstrate it an example. That's the biopsy of the lymph node with the presence of malignant cells. See, they're huge, a lot of them. So that's the metastasis into the lymph node. You see the lymphatic tissue around the cancerous cells. But routine hematoxylin and eosin staining doesn't help us to identify the origin of this tumor. But it's important to know because we can't apply the specific targeted therapy to treat this cancer if it's possible. Moreover, if we know if there is the presence of the malignant tumor in the lymph nodes, it's very hard to understand if it's the carcinoma, melanoma metastasis, or it's just lymphoma. That's why, with the knowledge of the specific proteins for specific types of tissue, we can use immunohistochemistry and pretty well identify the origin of this metastasis of this tumor. Look here, there's CD45 staining. CD45, that's the universal antigen of the lymphoid tissue and different leukocytes. And see here, the application of antibodies against the CD45 revealed the positive staining of the normal lymphoid tissue. See, lymphoid tissue is stained pretty good, but not cancerous cells. So that's definitely not the lymphoma. As about the epithelial origin, we applied antibodies against EMA, that's the epithelial antigen. And you see neither lymphoid tissue nor metastatic cells are reacted with these antibodies. They are not stained, they are stained negatively. There is negative expression of EMA over here. So this is definitely not the carcinoma, that's not epithelial cancer. Instead of that, there is the positive staining of malignant cells, metastatic cells, with the antibodies against S100. What is the S100? S100 is the marker protein for different neuroectodermal cells, cells of neuroectodermal region. It could be neurons, it could be different ganglion cells, but also the melanocytic tissue belongs to the neuroectodermal region. So if it's melanocytic region, we can specify and use the specific melanocytic marker like HMB, because you see melanoma metastases, they are really frequent and they are really dangerous. And yes, bingo, that's the melanoma metastasis. Also, we apply immunohistochemical technique to verify the hormonal status of different tumors, like tumors of the breast cancer. If it demonstrates the hormonal status, the positive staining against the hormonal receptors, it means that it probably would be sensitive for hormonal therapy. So that's good for the patient. Another very sophisticated and pretty good thing, that's the so-called histogenetic methods. And one of them is the fluorescent in situ hybridization. Another one is the chromogenic in situ hybridization. Almost the same principle like in immunohistochemistry, but here instead of the antibodies we use the fragment of DNA that we call probe, and instead of antibody we are looking for antigen. Instead of the protein, what we are looking for a specific gene in the nucleus, in the cells that we obtain after the sectioning in microtome. So after the microtomy, we obtain the sample, we remove the paraffin, and we can treat this sample with the specific probes which are tagged with either fluorochrome or, again, like in case of immunohistochemistry, substrate enzyme complex to visualize the presence of certain genes. Why we need that? We need that to verify the specific mutations in the tumors. Now, after the finishing of the project Human Genome, we know the consequence and exact amount of our genes and their structure, the consequence of nucleobases. With that knowledge, we can produce mapping of our genome. Moreover, if there is something wrong, if there is the appearance of certain mutations, we can verify these mutations, and in such a way we can identify the specific tumors which had some specific mutations. For example, oligodendroglioma, sometimes it's very hard to distinguish histologically, but it reveals very specific mutations, so-called 1p19q co-deletion. You see the nucleus, that's nuclei of the tumor in the brain, brain cancer, with the suspicion of the oligodendroglioma. And the confirmation that this is exactly the oligodendroglioma is here. You see the two green dots, that's the tagged centromeres of the first chromosome. So it means that there are two chromosomes in the tumor cell. In fact, that's normal because in all of the somatic cells we got the double number of chromosomes, right? So two first chromosomes, that's pretty well. But the gene, this one, there also must be two alleles, two genes in two chromosomes. Instead, we see only one of them, only one red signal. It means there is a deletion in one of the chromosomes for this gene, that's mutation. And simultaneously, the same tumor demonstrates the deletion in the 19th chromosome in the long branch of that. You see the one again, two green signals, two 19 chromosomes, and only one gene. It means another deletion. Another thing, another type of mutation, that's amplification. And amplification of so-called HER2/neu gene is the prognostic marker for the breast cancer. So this is the normal cell, the nucleus of the normal cell, more precisely. And in this nucleus, again, you see two centromeres and two genes, two HER2 genes. Instead of that, in the breast cancer cell, you see two chromosomes, but three markers, three tags of the HER2 gene. That's the amplification. That's also very important to know. And other quite sophisticated and expansive methods for their histological and cytological investigation. That's one of them is the confocal scan microscopy, which helps us to look directly into the cell. For example, here we can see the fluorescent microphotograph of the cytoskeleton in the fibroblast. Vital microscopy imaging is the future of pathology, I guess, because it permits us to visualize the cells in vivo. So we don't need to harvest tissues to take biopsies anymore. Maybe in future it could be like that. So here you see the vital staining of the cells. That means that the patient must intake some fluorochromes before the imaging, and then the microscope, which could be, for example, attached to the endoscopic technique, can visualize the epithelial cells in the small intestine. So far, this method is experimental and we can use it in animals because of some phototoxicity. Because we use laser, and laser can induce formation of the toxic products after the degradation of the fluorochromes. That's not so good, but I guess it would be improved in few decades. Widely used digital pathology, distant medicine, telepathology. Now that's the normal things, and you will see that during our classes. Then we will start to use virtual slides. The special techniques like microscope scans can produce the high resolution images of very large sizes and store them in the big data storages, and then we can send using the internet these high resolution images worldwide, and in such a way we can collaborate with the colleagues from abroad, from on opposite sides of the globe, and can improve the quality of the diagnostics. Now I just want you to represent the main stops in our road of the pathology. Pathology route consists of quite important milestones. It's like the big topics in the general pathology course, as well as the names of the seminars, as well as the lecture names during this course. So you see that's the cell and extracellular matrix injury. This is what we will start to discuss today, and I'll continue in next week. Then circulatory disorders, another lecture and another big topic. Inflammation, and you see there is some consequence of events, cell injury and inflammation as a response to damage. Then would be another lecture dedicated to immunopathological process, and our course also contains that. Then inflammation and the consequence of inflammation, tissue repair, together with aging and adaptation, will be discussed today and during the next classes. And after all, the end of the general pathology basically coincides with very interesting topic dedicated to the origin and development of the cancers. Carcinogenesis, tumor genesis as the last stop in the route of pathology for this fall semester. So now let me start the second lecture, which is dedicated to cell injury. I would like to start with this image. This is the schematic of the normal cell with all the cellular household, which is pretty normal over here. And just to remind you the basic structures, compartments of the cell, and to remind you that the cell, as you may know, is the structural and functional unit of the organism. And in the same manner, the pathology of the cell and cell injury, that's the structural unit of any disease. And any disease is starting from the injury of the cell. So, as you may see, the normal cell is confined to a fairly narrow range of function and structure by a state of metabolism, differentiation, and specialization, by constraints of neighboring cells, and by the availability of metabolic substrates. It is nevertheless able to handle physiologic demands, maintaining a steady state of the homeostasis. Though adaptations, this is the next point of our discussion, they are reversible, functional, and structural responses to changes in physiologic states and some pathologic stimuli, during which new but altered steady states are achieved, allowing the cell to survive continued function. The adaptive response, for example, may consist of increase in the size of cells, like hypertrophy, and logically it increases the functional activity of that. This is the hypertrophy. And you may see hypertrophy, the increased cell and organ size, often in response to increased workload induced by growth factors produced in response to mechanical stress or other stimuli, and it occurs in tissues incapable of cell division. The mechanism of hypertrophy could be explained by the different factors which may trigger the hypertrophy. That's the mechanical stretch, the increased caused by increased workload that activates the mechanical sensors like integrin receptors on the surface of, for example, cardiomyocytes. Second, that's the agonist molecules like alpha-adrenergic hormones and angiotensin, which could be increased due to different pathological conditions and physiological stress, like physical activity. And third stimulator, that's the growth factor molecules, that's the proteins, soluble proteins, which could be produced by the cell itself, neighboring cells, other cells, and these soluble factors stimulate the specific receptors for them. So altogether, these triggers finally induce the signal transduction pathways. These signal transduction pathways trigger the downstream effect. This downstream effect finalized with the activation of certain genes in the nucleus of the cardiomyocyte, and activation of these genes finally resumed with the production of the specific proteins like contractile proteins, which are responsible for increase of mechanical performance. And in such a way we see the definite way of adaptation, because increasing of mechanical performance means decreasing of the workload, and also some production of growth factors, which means self-stimulation of the cardiomyocytes. Another mechanism of the cell adaptation, that's hyperplasia. Hyperplasia, in contrast to the hypertrophy, that's the not increase of the cell size, but increase rather of the cell numbers in response to hormones and other growth factors again. It occurs in tissues which could proliferate in contrast to hypertrophy, which couldn't. So the difference is the type of tissue. Myocardium, as you know, myocardiocytes, they just can't proliferate in postnatal period. In contrast to that, smooth muscle cells, they are pretty well in that, and they can divide. For example, in case of the pregnancy, hormones and other changes in the environment of the myometrium here leads to the both hyperplasia and hypertrophy of smooth muscle cells in myometrium. You see, this is the uterus of pregnant woman. This is the normal uterus out of pregnancy. And this is the smooth muscle cells out of pregnancy. Again, the smooth muscle cells which are changed under the condition of pregnancy. That's the increase of the size of the cells. That's definitely the hypertrophy. But also there is the increase of the amount. That's the hyperplasia. Another good example of hyperplasia, that's endometrial hyperplasia, which may happen every month. Also, it's a hormonal dependent mechanism and mechanism of physiological hyperplasia. Atrophy. In contrast to hyperplasia and hypertrophy, atrophy, that's the decreased cell and organ size as a result of decreased nutrient supply or disuse. Disuse and decreased nutrient supply. Take notice. It's basically associated with decreased synthesis of cellular building blocks and increased breakdown of cellular organelles. Example, that's the hydronephrosis. The kidney, from outside it looks normal, I mean the size at least, like a normal kidney, but on the cut surface you see that instead of the normal amount of the parenchyma of the kidney, renal parenchyma, we see the cavity, that's the enlarged pelvis, and this enlarged pelvis appeared here due to the increased pressure of urine, secondary urine over here. Why we see the development of the increased pressure here? Increased pressure, that's due to the compression, occlusion of the urethra by different causative agents like stones, tumors of urethra, or for example the stones or tumors in the bladder, or otherwise it could be the different occlusions caused by trauma or genetic disorders. So finally it leads to the increased pressure of the urine and compression, continuous and chronic compression of the renal parenchyma. This compression in its turn leads to the compression of the microvasculature, and small capillaries don't deliver enough blood with enough oxygen and nutrients. It leads to the continuous atrophy, decreasing the mass of the kidney. The last type of the adaptation, that's metaplasia. Metaplasia is quite a unique thing. That's not neither increase amount nor the atrophy. That's change in phenotype, change in appearance of differentiated cells, often in response, for example, to chronic irritation. That makes cells better able to withstand the stress, usually induced by altered differentiation pathway of tissue stem cells, and finally it may result in reduced functions. A good example of metaplasia, there's the bronchial squamous metaplasia. You see the bronchial mucosa, the slice of the section here, there's the histological slide of the bronchial mucosa. There's the epithelium. On the left, you see the remains of normal respiratory epithelium, columnar cells, some goblet cells. I don't see them here, maybe here. And you see the ciliated cells. You see the cilia on the surface. And also maybe some intermediate stem cells. That's the normal appearance of the bronchial epithelium. But on the right, you see the multi-layered epithelium. It resembles squamous, non-keratinized epithelium, and that's definitely squamous epithelium. How it appears and why it appears? It appeared here in the bronchus. This is the result of the long-standing irritation of the bronchial mucosa. The best example is the smoking. Smoke, cigarette smoke may produce some irritation, first of all, the stem cells in the respiratory epithelium, and they trying to respond adequately against this stress stimuli. Okay, they just change the phenotype to the defensive type of the epithelium, like squamous one, and it seems good from the first glance. But in fact, that's really bad thing, because in spite of formation of defensive fence, the layer of the squamous epithelium, there is the abruption of very useful instrument in the very useful function of the respiratory epithelium. That's the mucociliary clearance. So mucociliary clearance is proposed to remove dust and bacterial particles with the flow of mucus by movement, regular movement of cilia, and with the regular production of the mucus by goblet cells. And the general requirement is the integrity of this epithelium. It must be not uninterrupted. But this interruption, as the squamous epithelium appeared here, leads to the accumulation of mucus here, formation of the mucus plug over here, and the blockage of the bronchus lumen, right? So that leads finally to the continuous irritation and the inflammation and chronic bronchitis after all. After all, it may lead to the hyperplasia of these cells, accumulation of different mutations, and after all, formation of the lung cancer. Well, if the limits of adaptive responses are exceeded, or if the cells are exposed to injurious agents or stress deprived of essential nutrients, or become compromised by mutations that affect essential cellular constituents, a sequence of events follows that is termed cell injury. Cell injury is reversible up to a certain point, but if the stimulus persists or is severe enough for the beginning, the cell surface suffers irreversible cell injury. Example, here in reversibly injured myocardium, here there are functional alterations, usually without any gross or microscopic changes, but sometimes with cytoplasmic, you see changes such as cellular swelling or fat accumulation. In the specimen showing necrosis, a form of cell death, you see the lower right area. The light area, light yellowish area, in the posterior lateral left ventricle, represents an acute myocardial infarction caused by reduced blood flow due to the ischemia. It's useful to describe the basic alterations that occur in damaged cells before discussing the biochemical mechanisms that bring about these changes. All stresses and noxious influences exert their effects first at the molecular or biochemical level. There is a time lag between the stress and the morphologic changes of cell injury or death. The duration of this delay may vary with the sensitivity of the methods used to detect these changes. See, with histochemical or ultrastructural techniques, changes may be seen in minutes to hours after injury. However, it may take considerably longer, hours to days, before changes can be seen by light microscopy or even later on gross examination. Here you may see the morphologic changes and differences between the reversible and irreversible stages. On the left, that's the renal epithelium. You see the light microscopy with the hematoxylin and eosin staining and the normal appearance of the renal epithelium cells. You see the nuclei, the eosinophilic, pale eosinophilic cytoplasm, and the brush of the microvilli for resorption, increase the surface area. Then under the electron microscopy graph, you see the presence of this microvilli, normal appearance of the nucleus, and the normal appearance of the mitochondria. Look in the medium image. That's the reversible changes in the cells. Look here, there is the loss of the macrovilli, some deformation of the cells with the formation of blebs on the surface. Also, we see the enlarged mitochondria. So this is the signs of the reversible changes. And after a certain time, the irreversible changes, necrosis occurs in the tissue, and with that we see some such changes as the disintegration, ruptures of the cellular membrane, the vacuolization with the huge mitochondria, this vacuolization of mitochondria, clumping of chromatin with the pycnosis, and finally cellular death. There are several mechanisms of cell injury. What you should know on the biochemical level, first that's ATP depletion. That's the failure of, first of all, of energy dependent functions, and starting from reversible injury, then leads to necrosis. It could be produced by mitochondrial damage, which also lead to the ATP depletion and lead to the same consequences. But under some conditions, the mitochondrial damage by itself may lead to the leakage of some mitochondrial proteins that may trigger apoptosis. Another mechanism, it could be independent from ATP, but also it could be induced by ATP depletion, that's influx of calcium. Calcium-dependent mechanism of cell injury based on the activation of the calcium-dependent enzymes, and the activation continuous damage of cellular components and may trigger apoptosis. Accumulation of reactive oxygen species, that's the formation of different free radicals associated with the oxygen, and basically we see the accumulation of that also in case of the hypoxia or ischemia, as well in case with some intoxications and radiation. Increased permeability of cellular membranes could be overlapped with ATP depletion, because also could be concerned with the work of the pumps, but also permeability could be changed due to the activation of the enzymes caused by influx of calcium, right? Or by other reasons like immune response, viral particles formation, etc. And other infectious agents, also physical and chemical agents. And after all, accumulation of damaged DNA and misfolded proteins, two independent mechanisms which may trigger, both they may trigger apoptosis. I would like to stop on the ischemic injury because it's quite important and very common in different pathologic conditions. First of all, what the ischemia is. This is not only hypoxia. You see, ischemia basically caused by the lack of blood supply in the artery which is supplying the tissue. So ischemia actually is developing in the tissue, and it's caused by the blockage of the supplying artery by thrombus or thromboembolism or just embolism or other occlusions of the supplying artery. After all, it leads to the lack of oxygen, lack of nutrients, and lack of removal of toxic metabolic products. That's like a triple strike. So all of these events leads to the depletion of oxidative phosphorylation, means depletion of ATP, and other downstream effects with influx of calcium, sodium, swelling of cell, then the depletion of glycogen loss, increase of the lactic acid, decrease of pH, with that denaturation of the proteins and clumping of nuclear chromatin, and detachment of ribosomes with the decrease of protein synthesis. Here they are, the four schematics of different pathways of basic pathways of cell injury: mitochondrial damage, entry of calcium, membrane damage, and protein misfolding with DNA damage. Mitochondrial injury very frequently is conducted with the increased formation of reactive oxygen species. In that case, we see the accumulation of superoxide, hydrogen peroxide, hydroxyl radical, which are not neutralized completely with the antioxidant system, and they produce the negative effect with lipid peroxidation that leads to the membrane damage, protein modifications which may lead to the misfolding of them and inducing of apoptosis, and DNA damage that may lead to the accumulation of mutations, and if they are not eradicated, they could produce the apoptosis again, induce the apoptosis. The two different pathways of the mitochondrial injury. First is associated with the oxygen deprivation or toxins from radiation, and leads to the decreased ATP generation and increased production of reactive oxygen species. All these events finally, in the end point, lead to the necrosis. Another mechanism that's the decreased survival signals, damage of DNA or protein, which may lead to increase of the pre-apoptotic proteins and decrease of anti-apoptotic proteins. We will discuss about that on the next lecture. Finally, these events lead to the leakage of mitochondrial proteins like cytochrome C, and this cytochrome C may trigger, organize the apoptosome and trigger apoptosis. Here you see the point of irreversibility, how it looks like under the electron microscopy. This is the enlarged mitochondrion with the vacuoles. These vacuoles means that there is the damage of the inner membrane of mitochondria, and the leakage of cytochrome C is imminent, which means imminent death of this cell. Calcium-dependent pathway could be induced either by influx of extracellular calcium or by release of calcium from membrane intracellular compartments like mitochondria and smooth endoplasmatic reticulum. Anyway, after all, we see the increase of intracytosolic calcium, which can activate different enzymes like phospholipase and protease, which is endpoint of membrane damage, endonuclease with the DNA damage, and ATPase, which may even worsen the decreased amount of ATP. Again, it may lead to the increased mitochondrial permeability transition, so-called MPT pore formation, and release cytochrome C. Then, again, activation of apoptosis. You see, a lot of processes, they are just overlapped. They induce each other, and we just can't elucidate just one distinct mechanism. All of them, they are cross-linked, cross-reacted, as well as cell membrane. You see, cell membrane damage, sometimes just if we imagine the rupture of the cell membrane by influence of tough physical and chemical agents, okay, it's possible as an independent mechanism, or like the influence of microbes, intracellular parasites, etc. But again, membrane damage may occur simultaneously with the calcium-dependent mechanism and ischemic injury. Let's resume everything what I mentioned above and resume that in the morphological key. Just resume and summarize the morphological findings that may represent, that may demonstrate the key features of reversible cell injury. First, you see that's the cellular swelling, fatty changes, plasma membrane blebbing and loss of microvilli, mitochondrial swelling, dilation of the ER, eosinophilia due to decreased cytoplasmic RNA, and the features of necrosis is increased eosinophilia, continuous of increasing of eosinophilia, is nuclear shrinkage, karyopyknosis, fragmentation, karyorexis, and dissolution, karyolysis. Again, karyopyknosis, shrinkage, fragmentation, karyorexis, and lysis, dissolution. Breakdown of plasma membrane and organelle membranes, abundant myelin figures as a result of autophagy. We will discuss about that next lecture. And leakage and enzymatic digestion of cellular contents. Next time also we will discuss about the patterns of tissue necrosis, like coagulative, liquefactive, caseous fat, and fibrinoid. Also, I will be focused on the different types of intracellular and extracellular accumulations. Now, I would like to discuss about the mechanisms of intracellular accumulations, and this is the sources what I used to prepare this lecture. So please don't forget to subscribe on our channel, don't forget to like this video, and don't forget to write your name and group in the live chat. Thank you so much for your attention. Have a nice day.